We had the opportunity to have one guest speaker for this symposium today, and I selected Dr. Mike Atkins, who's the Deputy Director at the Lombardi Cancer Center at Georgetown in Washington, D.C., because I think he's one of the clearest thinkers about the various different drugs that we have and the way we should think about using these drugs and what order and what sequence and why. So without further ado, I'll welcome our special guest, Dr. Mike Atkins, to talk about current treatment approaches for advanced melanoma. Mike, thank you again.
And bring you greetings from the nation's capital, where we're finally getting our spring weather and the cherry blossoms are finally out. It's good to see all these people coming out on a Saturday morning who have an interest in learning more about melanoma. So, historically, advanced melanoma or stage 4 melanoma, which I've been assigned to talk about, has been a bad disease. It's the 9th most common cancer, so there are a lot of other cancers that you hear more about, but in terms of potential life years lost, it ranks second because it affects young people in the productive period of their lives, and it's the biggest cause of cancer-related cause of motherless families. The mortality, unfortunately, has been increasing compared to other cancers, and historically, before the new drugs came along that I'll mention here, median survival, meaning how long half the people would survive, was stuck at 6 to 9 months. And although we work very hard, those of us in the medical oncology field, to develop new therapies, few of them had any effect, and the number of positive trials where we compared one therapy to another and saw one being better than the other was 0. So the melanoma investigator community, and I think a lot of the patients, a lot of the doctors that you might have seen, primary care doctors, were all demoralized and felt that this was a disease that really couldn't be treated. And you still see some of that left around in people who haven't kept up with the new literature. This was the survival curve. What this shows is how people live over time and it's the probability of surviving over time. And as you can see, very few people are living 2 years, and very few people live longer than 5 years. And many of those people who were living longer than 5 years probably were incorrectly diagnosed as having stage 4 melanoma. So one thing I just want to pause here, and I don't know if someone said this already, but stage 4 melanoma is cancer that spread to distant parts of the body. It's completely different than Clark's level 4 melanoma, which has to do with the level of thickness of the primary tumor. It was Clark's level 4 melanoma is frequently curable, even with surgery alone. Stage 4 melanoma, historically, only a few percentage of patients were cured. But not all stage 4 melanoma is the same. Patients who had primarily disease that was confined to their lymph nodes or skin, what we call M1A disease, tend to do better than patients who had disease confined to their lung. And that group tended to do better than those who had disease in other organs, liver, spleen, brain, bowel, or those who had disease in any site and an elevated blood test called an LDH. And those groups tend to do the worst and were called M1C. And one of the things that's important to know if you're a patient taking care of melanoma is what the LDH is. Because the serum LDH, which has been added to the staging system for advanced melanoma, appears to be the most important factor regarding prognosis, where median survival and the percentage of patients alive at 1 year is double for patients who have a normal LDH relative to patients who have an elevated LDH. And so this is an important thing to know, and any oncologist who knows how to take care of melanoma should be ordering and LDH on their patients with stage 4 disease in order to categorize what their risk is, and also, as I'll get into, potentially help select treatments. So we were doing poorly in terms of developing therapies, but it was not for lack of trying. Every one of these little dots here in this particular slide on either side represents a clinical trial of a new substance for treating patients with advanced melanoma that somebody thought would work better than the standard therapy. And what these curves are what you would expect just randomly for the range of where trials would fall if they were ineffective. So in order to be an effective therapy, you would typically fall outside of these curves. And for 70 trials, both looking at overall survival at 12 months and progression-free survival at 6 months, there was only one study that even got just beyond those curves, and that was a study looking at a chemotherapy regimen that's in subsequent phase 3 trials compared to standard therapy turned out to be not better than standard therapy. And this is a quote from Dr. Sondak, which says, with 70 phase 2 trials evaluating inactive agents, we would expect to see at least 3 that were outside these curves. So it just shows you how hard it was for us to move the bar with these new therapies for melanoma over the years. And this is sort of true with chemotherapy. It's not that nobody benefits from chemotherapy. The doctors have seen patients who've benefited from chemotherapy. But when you look at a whole host of patients, it's hard to show that there's a significant benefit versus no therapy. And the standard chemotherapy is dacarbazine, or its oral form, temozolomide. And right now, there's no evidence that that's better than anything. And there's no evidence that combining something or adding something to dacarbazine is superior to dacarbazine alone. There's some early data that suggests that other chemotherapies like carboplatin and paclitaxel, or a new drug called nab-paclitaxel, or it's called Abraxane, which has been used for breast cancer, may be better than dacarbazine, but it's not yet definitive, and there are a lot of things that we thought were going to be better in phase 2 trials or phase 3 trials than when subsequent trials were done, proved to not be as good as we had hoped. The standard therapy, which many of us use for patients, was high-dose IL-2. It was approved in the late 1980s, and it was approved because of this particular figure. And what this figure shows is the progression-free survival, or the duration of response for patients who've had a response to IL-2. If you had complete response, which means all your disease on the CAT scan went away, you were likely to stay in complete response. As a matter of fact, none of the patients who were in complete or partial response after 30 months have had a recurrence, now being followed for almost 20 years for some of those patients. So these patients out here are all likely cured of their melanoma, stage 4 metastatic disease, cured with IL-2. The problem is that only 16% of patients get a response. Only about 6 to 10% have these complete responses that are durable. And for the majority of patients, they fall into this category here, and they're not really helped at all by the therapy. So it's useful in a small percentage of patients, but it also is inpatient. It has a lot of side effects, very expensive, it's impractical, and therefore its use has been limited to selected patients treated at experienced centers, and doctors who don't give IL-2 will usually not recommend IL-2, even at major academic medical centers. And so they may not even tell you about it, or they may say it just has a lot of side effects and it doesn't really help anybody. But those of us who've used IL-2 over the years know we have a lot of patients who we're continually seeing in our clinics who have benefited long-term from high-dose IL-2. But because it's far from an ideal therapy, and efforts to better identify the patients who are the ones who are benefiting are really important and something that we've been focusing on. So that's sort of my background. I'm going to talk now for the rest of the talk about what's new over the last 5 years with the standard therapies and leave a lot of the new investigational treatments to the people who are following me, particularly Dr. Weber. So I'm going to talk a little about immunotherapy, updating some work on IL-2, and also talking about the new immune therapy, ipilimumab, or Yervoy, and then talk a little bit about research that's been done targeting molecular changes within the tumors, the c-KIT inhibitors, the BRAF inhibitors, and also combinations of BRAF inhibitors with MEK inhibitors, and then talk about some future studies with molecularly targeted therapies. And then, as Vern alluded to, talk about how do we use these practically in the clinic today. So not all patients necessarily are the same with their ability to respond to IL-2. We retrospectively looked at how molecular changes within the tumor might predict for who's going to benefit from IL-2. And in a group of about a couple hundred patients, 100 of whom had their tumors typed to see whether they had either BRAF mutations or NRAS mutations, the response rates looked like they were at least as good with IL-2 in patients who had mutations in their tumors, maybe a little better with IL-2 in patients with NRAS mutations in their tumor than the patients who had no mutations in their tumor. So just because you have a mutation in your tumor doesn't mean that you should start out with a treatment that targets that mutation, and I'll get back to that in a while. LDH is also can predict who's going to do well, at least with IL-2. Patients whose LDH is normal appear to be the ones who respond to IL-2, and those who have an elevated LDH or more aggressive tumor biology are much less likely to respond. Here, only 2% of the patients are having a response. 6% of the patients, 2 patients out of 32, are having a response, and none of those responses were complete responses. We tried to see whether, in the community, whether we can improve upon IL-2 by adding a vaccine, and this was a peptide vaccine that was identified at the National Cancer Institute as something that immune cells recognize when they were destroying melanoma cells. So patients were given a vaccine and IL-2, or given just IL-2 alone. And as is often the case with immunotherapy trials, there was no difference between these two groups for half the patients, but it looked like the patients who got the vaccine appeared to do a little better in terms of those staying free from progression long term, with this red curve being above the blue curve. So that suggested the vaccine might add something, and this was actually, I think, picked up by the lay press and in Time magazine when they mentioned the 100 most influential people at the time. They mentioned some doctors, including Doug Schwartzentruber, who was the PI of this trial, so he was right there with Bill Clinton and Lady Gaga as being one of the 100 most influential people. But as is often the case, the result was not that clear. We're not really sure that this was a proof of concept that you could actually improve immune therapy with a vaccine. It could be, but it seemed to many of us that the IL-2 therapy patients were doing worse than they would have anticipated. And if you just took 5 patients in the IL-2 group and had them respond, then the curves would have overlapped. So even though this was a lot of effort, many patients being enrolled in this trial, we're still not 100% sure that the vaccine actually added to IL-2 therapy. But if it did, it may be that other vaccines might add to IL-2 therapy, or that this type of vaccine might be something that could add to other immunotherapies, such as ipilimumab. The other thing that we've looked at is I mentioned that not all melanomas are the same, but maybe we can tell by looking inside the tumor which ones are going to respond to immune therapy or not. And some have this non-inflamed phenotype where they have a lot of vascular cells, a lot of cells that suppress the immune system there, and they just aren't a microenvironment that's set up to allow immune cells to get in and destroy tumor cells. And those type of tumors we might be able to identify by looking at what proteins are expressed, what genes are expressed, what proteins are made by those tumors. There's another type of tumor cell property that makes up about a third of melanomas, where they have immune cells that have come in. They have cells that could possibly kill a tumor, but they don't work because the tumor has developed defenses that actually prevent the immune system from working. And if you could just figure out ways of blocking those defenses, you might be, or getting around them, you might be able to get the immune system, which has recognized the tumor, to actually working and kill the tumors. And Jeff Weber is going to talk a lot about that concept and how we've used that to develop adoptive T-cell therapy or to block a component here called PD-1. But we can also use this to potentially select which patients might benefit from immune therapies like IL-2, or potentially bring in more effective lymphocytes into the tumors, which we can do with drugs like ipilimumab. So when we look at immune infiltration within the tumors, it looks like that if you have a lot of immune cells here in the tumor, and those are these dark blue things here, that patients tend to do better overall. This is work from Craig Slingloff at the University of Virginia, suggesting that the survival of patients with immune cells in their tumor, particularly if they have a particular type of immune cells that can recognize and kill tumors called CD8 cells, they tend to do better. And so we looked with IL-2. We treated a group of 50 patients when I was in Boston at Dana-Farber Harvard Cancer Center, Beth Israel Deaconess, with high-dose IL-2, more contemporary data. And we found that not only was the response rate higher than is in the package insert, where there was now about 25% to actually a third of patients who were actually responding to IL-2, but that when we looked at using gene expression studies to identify whether they had this immune infiltrating class of tumors or not, majority of the patients who had this immune infiltration tended to respond to treatment, while a smaller percentage of patients who had this non-inflamed type of tumor tended to respond. It wasn't zero, so it wasn't an absolute selection criteria, but it provided us with a clue. And the patients who had the immune infiltration tended to have better quality responses as well. So in looking at this, trying to predict who responds to IL-2, we can say that the activity of IL-2 may be better than in the current era than it was when we first did these studies in the 1980s and early 1990s, and that's probably because we use things like LDH to tell us who can receive IL-2 or not. But we can also potentially identify through things like gene expression signatures. And there's work being done on that here at Moffitt to further refine that type of research, who might do better with immune therapy than others. And also this sort of association of benefit with an immune response signature may be a potential clue to the mechanism of action of IL-2 and potentially other immunotherapies that have helped us, I think, advance the field, as Dr. Weber will get into. So I'm going to move to ipilimumab, or the CTLA-4 antibody, and this is a different way of activating the immune system. As it turns out, when a T cell recognizes a protein on the surface of a antigen-presenting cell, what we call a dendritic cell, it has two signals that need to bind, and it becomes activated. But one of the things that happens when that T cell becomes activated, it puts another molecule, an immunoinhibitory molecule, on its surface, which outcompetes these orange molecules for binding to this secondary signal. And that tends to shut the immune system off. The reason why it's there is so that your immune system doesn't go crazy and destroy your body every time it recognizes something that's foreign. So it's a check on the immune system. But that limits the ability of the immune system to kill cancer cells, which have proteins on their surface that make them look foreign. And if you give this antibody, ipilimumab here, it blocks that particular interaction between CTLA-4 and this molecule B7. It allows the immune system to stay active and hopefully have a better chance of killing tumors. So, knowing this, when that antibody was developed, we wanted to see whether or not it worked better than standard therapy. So in patients who had received all different types of standard therapies, they were randomized in a clinical trial to receive ipilimumab at a sort of standard dose, plus that same vaccine I mentioned before, GP100, or a placebo, or just getting a placebo vaccine. So this was a very difficult trial for people to do because not everybody was getting an active therapy. Some patients were getting a vaccine that may not have been that active, although it may have been the best option for them considering they had received other prior therapies. But it was still a lot of dedicated patients who went in to this trial to try to help us determine whether these new drugs actually worked better than standard therapies. And what we found in this trial, and this was the first time we've ever found this in patients with stage 4 disease, is that patients who got ipilimumab, whether it was with the vaccine or with a placebo vaccine, tended to live longer than the patients who just got the vaccine. And so there was double the number of patients alive at 1 year, and also a large percentage of patients, around 25%, who were alive at 2 years. And what we also learned is that sometimes tumors could actually get worse before they got better. So here's an example of a CAT scan with a lot of soft tissue nodules here right on the abdominal wall. And this looks like it actually got worse 3 weeks into treatment. And the doctor could feel this, and the patient could feel this, the tumors were bigger. And so ordinarily we would have said, this treatment isn't working. But we waited. And what happened was, by 4 months, these tumors were going away. And about 10% of the patients had this type of process where their disease looked like it got worse, but then it got better. And so we learned to not rely too much on early changes with this drug. And if you look at the patients who had a good response to treatment, right here in orange, they tended to do very well. But the patients who had this pseudo-progression where their disease got worse and then got better tended to do almost as well as the patients who just responded. And they all did better than the patients who didn't have a response. And if you looked overall, when you combine those patients who had true responses and pseudo-responses, and then looked at how people were doing overall, about 25% of patients were living 2 years, and very few patients who were alive and had responded at that time have relapsed since then. So similar to IL-2, if you had a good response and it lasted 2 years, there was a good chance that you were going to be cured with this immunotherapy. And that's a property of immune therapy, is that patients who have lasting responses, meaning more than 2 years, have a high chance of being cured. But unfortunately, this treatment had some side effects, because not only did it activate the immune system against the tumor, but it tended to allow immune cells that might recognize normal tissues to also become activated. And that was in specific areas, such as in the skin, where you could see a skin rash, in the GI tract, where patients could get colitis, in endocrine organs, particularly the pituitary gland, where they could get something called hypophysitis, and in the liver, where they could get hepatitis. And that could happen anywhere from 40% down to 3% of patients. And this is data that actually came from a publication from Dr. Weber this year in the Journal of Clinical Oncology, which talked about the kinetics of those toxicities, where the rash happened earliest, then the colitis tended to happen. Didn't happen early in treatment, but somewhere after the second or third dose, we started to see these type of toxicities, colitis happening somewhere around 5 to 10 weeks, liver toxicity happening 7 to 14 weeks, and pituitary happening around the same time. And we initially were it was difficult for us to manage these things because we didn't want to give steroids to someone who had an immune response going on, because we thought from our IL-2 days that would dampen the immune response and it would ruin any benefit that was going on. But in some patients, we were just forced to give them steroids, and because we couldn't treat their disease otherwise, they were very sick. And we saw that the disease responded to the toxicity responded to the steroids, got better, but the anti-tumor effects of the treatment tended to persist. And so now we've been much more liberal, much more aggressive at giving steroids to patients who are on ipilimumab who are experiencing these type of toxicities. So when we look at ipilimumab, it enables immune responses and anti-tumor responses in some patients, maybe as many as a quarter of the patients. The activity is powerful enough to work in the central nervous system, as Dr. Gibney will mention, and to overcome concurrent immune suppression with steroids. The response appears to be, at least in many patients, at least partially associated with autoimmunity. So if you see autoimmunity, it's not always a bad thing, because that may be a patient who might be slightly more likely to respond. Activity is seen in patients who've had prior IL-2, and it wasn't restricted in any way by prior BRAF mutational status. So this really represents an option for many patients with advanced melanoma, but timing of therapy, management of autoimmune toxicities require attention. And in my opinion, not enough patients with advanced melanoma, particularly those with BRAF mutations, are receiving this therapy, and I'll get to that later. So there's still, even though it's an approved drug, there's still many unanswered questions about how to use this drug. Whether we give this regimen with dacarbazine or not, whether it should be a first-line treatment or a second-line treatment, whether we use a 3 milligram dose that was approved or whether a 10 milligram dose would work better, whether we give it just 4 doses or whether we give maintenance every 12 weeks during the course of a year. What's the role in the adjuvant setting that was talked about previously by Dr. Kay? And how do we combine it with other therapies to potentially make it work better? So all of these are research questions that are studies where people can participate in, where they get an active therapy, but the question is, can we improve upon it for one reason or another? So not all research has this placebo control and people getting treatments that might not work. Here's where we're trying to learn how to use these type of treatments better. And so a number of these protocols, I'm sure, are open at Moffitt, and there are things that people could consider. Moving on to molecularly targeted therapies, any cancer cell is very complicated inside, and this is a simplification of what's going on inside a melanoma cell. There are a lot of pathways that get activated, and some are activated in very specific ways by mutations in certain proteins within the tumor. And one of the most common one is a mutation in this gene, BRAF, or this which causes an abnormal protein to be made which can't shut itself off. And that causes this pathway, which has MEK and ERK below it, the MAP kinase pathway, to be driven without any brake on it. So that was discovered a decade ago, that these mutations happened in melanomas. In addition, about 20% of tumors have mutations in another, or 15-20% have mutations in another parallel pathway called NRAS that can go through the BRAF pathway or go around the BRAF pathway, and those tend to be complementary, and that tells us, gee, this must be important. The tumor has one or the other, but never both. It doesn't need a second one if it has one. And then there are other mutations which can happen in certain types of tumors, like mucosal primary melanomas, which can have mutations in c-KIT. And there are other abnormalities that happen in other pathways that may help us to identify what treatments might work. So not all melanomas have the same mutation patterns. This is data from a study of a variety of different types of melanomas, which suggested that for patients who had melanomas and didn't have a lot of chronic sun exposure, or they were younger people with a lot of moles, they tended to have melanomas that were more likely had BRAF mutations in them, while melanomas that formed in older people or chronic sun-damaged skin tended to be more likely wild-type or NRAS mutations, occasionally c-KIT mutations, while mucosal melanomas, if they had mutations or abnormalities, were more likely to be in c-KIT. So first thing we actually looked at before we studied BRAF inhibitors was to see whether drugs that inhibit KIT could work in mucosal melanomas, and particularly those with mutations. And there were some drugs around because these drugs were approved for leukemia and other type of cancers. And in some patients, this is a PET scan. Here's a tumor with that arrow there that sort of lights up on a PET scan like a light bulb. You can see multiple different tumors lighting up in this particular patient. And within 4 weeks of treatment, all those light areas were essentially gone with a KIT inhibitor in this particular patient. So that was really exciting. It led to a publication from my colleague, Steve Hody, and it led to a lot of clinical trials. We at Harvard, when I was there, had 4 different clinical trials going on with KIT inhibitors in patients with melanoma. But unfortunately, KIT mutations, as it turns out, are only in about 1% of all melanomas. And if the KIT gene is just amplified but not mutated, it doesn't seem to respond as well to these KIT inhibitors. So this whole process is of interest for some patients, but it's really not the answer for the majority of patients with melanoma. So what was more interesting was the RAF inhibitors. So there were studies done in animal models which suggested that if you had a mutation in BRAF in your tumor and you put that tumor that had a mutation on the flank of a melanoma and gave a flank of a mouse, and then gave them a BRAF inhibitor, in this case this is vemurafenib, that tumor responded and stopped growing. Well, if you took a wild-type tumor, put it in the flank of a mouse, and gave them the same drug, you saw no benefit. So this suggested that maybe this might be a therapy that might work. But it was not really easy to do this development of this drug because the first pills that were given didn't show any benefit, and it looked like part of the reason why it was no benefit is we weren't able to get to a high enough blood level to actually inhibit the target. So when that was realized, the investigators, scientists at the company that makes vemurafenib reformulated the drug so that it was more bioavailable. So when you took a pill, you got a higher blood level. And so these red dotted lines are the same level, but this new reformulated drug got a much higher blood level and over the level that was needed to inhibit the protein. It was only then that we started seeing remarkable responses similar to the ones I showed in that patient who was treated with a KIT inhibitor. These are all PET scans of 4 different patients within 2 weeks, showing these areas where the tumors were, which are here lit up largely in black or in some in white, getting much better within 2 weeks taking vemurafenib. And we knew early on this was going to be a valuable drug because the patients who got vemurafenib had a much better progression-free survival than the patients and those who had a mutation in the tumor than those who got vemurafenib either at a subtherapeutic dose or had no mutation in their tumor, similar to that mouse data that I showed. And so this suggested that there's no reason why these tumors the wild-type tumors would behave any differently than the mutated tumors in terms of their prognosis. So it suggested the treatment was what was making the difference. And so when we did bigger studies, this is called a waterfall plot because it shows amount of tumor shrinkage over time from least to most in each of these bars as an individual patient on the trial. And you can see that 80% of these patients are getting some level of tumor shrinkage. And if it's more than 30%, we call that a partial response. If it's 100%, we call that a complete response. So this was a type of pattern of response that we'd not seen with any drug for melanoma previously. So that prompted people to do the hard study, which was a phase 3 trial comparing this drug to standard therapy, dacarbazine. And this was a difficult study because nobody wanted to go on the dacarbazine arm, but they couldn't get access to vemurafenib otherwise. And when this study was done, very quickly we saw within 6 months of the study opening and 3 months of the last patient being enrolled that the vemurafenib group was doing considerably better in terms of how long the disease was being held in check compared to dacarbazine. And that allowed the study to be unblinded and patients who were on the dacarbazine arm to cross over to get vemurafenib. And when you look at overall survival, there was also, as I noted with ipilimumab, there was benefit in terms of overall survival, and this is the second drug now that has improved overall survival. And in this study, it was about 14 months compared to the standard 9 months that I've mentioned before is what we were seeing historically. It's slightly worse for reasons that we can debate than what was seen in that phase 2 study where everybody got vemurafenib, but clearly beneficial. But what's seen is that not everybody appeared to benefit in terms of overall survival equally. This is what we call a forest plot. And if you're on this side of this red line, that means you're getting benefit. And most of these bars are on this side of the red line, but the patients who tended to benefit the most were those who had the most aggressive disease, what we call the M1C disease, patients who had the elevated LDH and the organ site involvements. And they tended, while the patients who had M1B or M1A disease didn't tend to do as well relative to dacarbazine, and it's possible that's because they were able to get back onto vemurafenib because they were still alive afterwards, or they could go on to other therapies like immune therapies. And so this sort of highlighted that you wouldn't necessarily choose for everybody vemurafenib as your first treatment. So these drugs were much better tolerated than previous therapies, but they still had some side effects. They caused rash, they caused photosensitivity, they caused joint pains, and they caused these skin cancers, which look like this. They're like squamous cell cancers, and they would develop and they needed to be resected for many patients. And we learned about what caused them to happen. Here's an example of a photosensitivity. I don't know how well you can see this, but this is someone who was wearing sandals and has intense sunburn at the site where the skin was exposed on the top of her feet. And when do these squamous cell cancers happen? Usually early in treatment, and they're probably pre-malignant processes that were there already that were being activated by blocking the BRAF pathway, but allowing the RAS pathway to be unblocked in those cancers. And so we know if you give this drug, you need to also be followed by a dermatologist to watch for these type of lesions and to have them treated. So there's a second BRAF inhibitor that's developed from another company called GSK, and that drug is called dabrafenib. And when you look at the waterfall plots of these two drugs, they're identical. So you can't tell from an efficacy standpoint whether one works any better than the other. But also, dabrafenib had very few serious side effects or treatment discontinuations. The side effect profile, this is drug is not yet approved, but it will be probably soon, is the side effect profile is slightly different than vemurafenib. There were less skin abnormalities, there's less phototoxicity, but there's more fever happening in about 15% of patients where it's rare in vemurafenib. So given the fact that they have similar efficacy, these toxicity differences may ultimately determine how they're going to be utilized. And in looking at dabrafenib, it's, I think, the second BRAF inhibitor with proven efficacy. FDA approval, as I mentioned, is likely, hopefully soon. And for those of us in this field, competition is good, both for patients and for doctors, because hopefully it will in some way drive the prices down or at least give people options. So, but BRAF inhibitors have some limitations, just as I said for immune therapies. Median progression-free survival is only 6 to 7 months, median overall survival 13 to 16 months, and the benefit relative to DTIC is mostly in the patients with the most aggressive diseases. So it's, how can we build upon this? So combinations with, by adding to BRAF inhibitors, a MEK inhibitor may offer some advantages. And that's because what happens is when you block BRAF here, you can still sometimes signal through this pathway through CRAF. And sometimes that pathway gets upregulated when you're blocking BRAF. And so the thought was that if you could give a drug that blocked downstream here and blocked MEK, you might be able to control some of that resistance that's being developed. And there were studies that were done that showed that you could see some activity with those combinations, and that led to a randomized phase 2 trial where patients were either treated with single-agent dabrafenib or the combination of dabrafenib and the MEK inhibitor at 2 different doses. And I know that this study was, a lot of patients were enrolled at Moffitt, so maybe there are people in the audience who were on this particular study, which was published in the New England Journal. And when it was published, it showed that the combination, whether given with a low dose of the MEK inhibitor or a higher dose of the MEK inhibitor, seemed to do better than the single-agent therapy in terms of not only tumor shrinkage, but also in terms of progression-free survival, with now moving the bar on to 9 months. And from a toxicity standpoint, instead of, there were some toxicities that appeared worse, like some fevers, or maybe some GI toxicities, but there were other toxicities that were better, less skin toxicity, and particularly less of these skin cancers. So not only was it more efficacious, but some of the most troubling toxicities were less. And so I think this is a step forward. We're trying to prove that this is actually better than single agent with phase 3 trials. Those are ongoing. But it's possible that we will soon be able to build upon BRAF inhibitors by adding MEK inhibitors in routine practice. But I still need to point out that median PFS is still only 9 to 10 months, so we've got a ways to go before we achieve our goal of having patients actually, a large percentage of patients actually being cured. So let me get back to where we're at with 2013 for treatment algorithms. So if we look at first-line therapy for patients with BRAF-mutated melanoma, or BRAF wild-type melanoma, we'll start with that. Based on phase 3 evidence, ipilimumab is the standard treatment. High-dose IL-2 is an alternative, and as I mentioned, there's still a lot to be learned from clinical trials. How about for BRAF-mutated melanoma? Now we have choices of ipilimumab and vemurafenib based on phase 3 evidence, and IL-2 also works in that setting, and there's also a lot of opportunity for clinical trials. So one of the things we get asked a lot is, how do we sequence ipilimumab and vemurafenib in BRAF mutant patients with BRAF mutant tumors who have access to both? So one of the things we've seen is that BRAF inhibitors tend to work as well whether you've had prior immunotherapy, in this case IL-2, or not. On the other hand, and that's just shown here in a bigger data set, that if with ipilimumab or IL-2, that if you've had prior immunotherapy, you tend to do as well with a BRAF inhibitor in terms of PFS and overall survival, as you would do if you were treatment naive. It may not be the case with trying to give immunotherapy after vemurafenib. We looked at about 193 patients who had gotten BRAF inhibitors, 176 who had gotten it and then had progressed. And then the overall survival in that group of patients after stopping treatment was about 3 months, which is really disappointing when you think about how much benefit you're getting, but when you stop the treatment, the benefit tends to stop very quickly. And of the 34 patients who went on immune therapy after BRAF inhibitor, none of them responded. And the only patients who were still alive, there were some patients who were alive, most of them did very poorly, were those who went back on a BRAF inhibitor for one reason or another. And so we worried that BRAF inhibitor therapies may not be the best initial option for all patients with BRAF V600 mutant melanoma. And the current data suggests that for many patients with BRAF mutant melanoma, particularly those who are asymptomatic or have a normal LDH or may have an immune infiltrating their tumor, starting with immune therapy offers them the best long-term benefit without compromising their benefit from subsequent BRAF inhibitor therapy. But that's retrospective data, and prospective clinical trial data is really necessary to address this issue. But it stands to reason that for many patients, 2 shots on goal are better than 1, especially if you've got Landon Donovan here and David Beckham. And I was giving this talk in LA, and the LA Galaxy had just won the MLS Cup. And I was giving it as a debate against Tony Ribas. And he sort of said, well, it's better if you just have one a Lionel Messi. So here's the trial that we're hoping to get forward, which looks at patients for different sequences, either starting with a BRAF inhibitor, either vemurafenib or vemurafenib plus a MEK inhibitor, versus, and then switching to immune therapy at time of resistance versus the converse, and see which ends up with more patients alive. So finally, there are also trials that can be done with patients with BRAF mutant melanoma. A lot of unanswered questions, a lot of opportunities for building on BRAF or BRAF MEK. These are some of the things that people are looking at, adding PI3 kinase inhibitors, adding VEGF inhibitors, adding IL-2, adding CTLA-4 blockade, etc. We've looked at adding VEGF inhibiting drugs that inhibit angiogenesis, and it seems like that the BRAF mutant melanomas have upregulated angiogenesis, and at time of resistance, that angiogenesis is restored. So combining a drug that inhibits angiogenesis might actually add benefit, particularly in patients who have aggressive tumors. And so with the Melanoma Research Foundation Breakthrough Consortium, we're looking at a combination of vemurafenib plus or minus bevacizumab in a clinical trial that's opening at many sites around the country, hopefully here at Moffitt too, in the next month or so. But we also want to see if we can combine BRAF inhibitors with immune therapy. And we worry about that because we worry the immune response can sometimes be very sensitive to drugs that might inhibit it. And so we were encouraged by work that suggested that when you gave a BRAF inhibitor, you might actually increase tumor antigen expression in the tumors and actually increase immune cells coming into the tumors, that suggested that maybe you might set up those tumors to respond to immune therapy, but we still have no idea how to schedule that, and it seems if you wait too long, it might be too late. And so trying to figure out how to combine BRAF inhibitors with immune therapy is a major effort that's going on. There are a lot of trials that people are considering. One that was just published recently looked like combining vemurafenib with ipilimumab was too toxic. So maybe we'll be able to combine drugs with IL-2 or with PD-1 antibodies or with adoptive T-cell therapy, something that Jeff Weber may talk about, but it's not easy, and we need to do this as part of organized clinical trials rather than just empirically, because patients can get hurt. So where are we trying to go? Well, we used to be here with ipilimumab and BRAF inhibitors. We're sort of here. But hopefully with combinations, we'll be here. And hopefully with using optimal combinations of BRAF inhibitors and immune therapies, we'll be here. And maybe with trying to use some of the newer drugs and newer research, we'll get to where our goal is, which is to make the disease go away for all patients. But I think as you talk about stage 4 melanoma, you have to really realize that the best way to prevent stage 4, to treat stage 4 melanoma is to prevent people from actually getting melanoma. So some people have gone to extremes to prevent people from getting sun exposure, but it's important to realize that it's much better not to have stage 4 melanoma. But it's fortunate we finally have some treatments for those patients. Thank you very much.